today we are talking about the pediatric genitourinary tract, okay? So of course, it's pretty much, there's some things we're going to talk about that's genetic that you're going to see early on that you would not maybe see in adulthood. Something may have been repaired or fixed when it's a child. So we're going to look mainly at those, but we are going to talk about some things that you're going to see that adults can go through too, okay? So, our genitourinary problems in pediatrics. This is chapter 52 in your book, okay? There's lots of good information. There's some charts in there. I uploaded a video, kind of like a review of the urinary system, how your kidneys work, how your bladders work, how your ureters work, because you need a review. Yes. This is the second lecture in E. Okay. So, guys, I got a couple notes in my PowerPoint on here. I need to open it. So we have our learning objectives that we will be going over through this lecture, okay? Pages. We're going to talk about some things you may have heard about, like Wilms tumor, prune belly. Not everybody has heard of those things. They're pretty interesting. There's pictures of, or the prune belly, there is a good picture in your book that really depicts what it looks like. So we're going to kind of talk about the development of the genitourinary system. So tell me what two words we're combining to create this system. Okay, reproductive, so the gynecological, genitalia. Okay, so remember how we talked about breaking down your words. So if you're unsure of what a word means, try to think back to what you learned in kind of like those medical terms. Okay. So urinary is the urinary system, the kidneys, ureters, bladder. So this is just the development of the genitourinary. So it talks about toddlers compared to adolescent, because they're not the same when you're born. They still kind of mature, just like your reproductive system matures, okay? So all nephrons are present at birth. The ureters are short, and the tubules have smaller surface area, resulting in diminished water reabsorption. So they don't reabsorb water as well, okay? So think about those babies that are failure to thrive or go through dehydration, okay? So nephrons grow in size in the kidneys, and the tubule system gradually develop during childhood to reach adulthood size during the adolescent period, okay? So glomerular filtration rate, or that GFR, in a neonate is 1/3 to 1/4 of the adult level. The GFR increases progressively and reaches the adult level between 1 and 2 years of age. Okay, so that's something that's not fully developed. Kidneys are less efficient at regulating electrolyte and acid-base balance and less able to concentrate urine. Diarrhea, infection, and improper feeding may lead to severe acidosis and fluid imbalance. So that's why it's very important, if these kids are vomiting or having diarrhea or not feeding well, they get sick quickly, okay, because their body cannot process the urine and those toxins as quickly as an adult or adolescent can. Efficiency of the kidneys as regulating electrolytes and acid-base balance increases after 2 years. Expected urine output of a neonate and an infant is 1 to 2 mLs per kilogram per hour, while an adult should have about 0.5 milliliter per kilogram per hour. So in children, of course, we know women are born with all the eggs they'll ever develop. Men develop sperm throughout their lifetime, but it's still immature, okay? Those do not mature until adolescence, when those hormones kick in and start maturing them. The reproductive system matures after puberty, okay? So some things that we know about the urinary tract changes as we grow and get older, okay? Liz, what is a UTI? Correct. Urinary tract infection. Good job. So we're going to talk about what UTIs mean in children compared to whenever you are an adult, okay? Good job, whoever Dr. Singh. So urinary tract infection, we're going to look at what causes these to occur. So we know they can be bacteria, they can be viral, or fungal, okay? So it may involve the urethra and the bladder, that lower urinary tract. It could involve the upper portion, which is your ureters, renal pelvis, calicus, and which is those things inside the kidney, or your renal parenchyma. So that's the upper portion of your tract, okay? As babies, boys especially tend to get UTIs more frequently than girls. In childhood, girls get more UTIs than boys due to the short urethra. So it's a shorter distance for that bacteria or virus to move up into the bladder of a girl. Yes?
The girls was shorter than the boys. Like their urethra.
Yes, in childhood.
What about babies?
It is somewhat, but you have to think about boys when they're babies. If they're not circumcised, they have a greater risk of getting UTIs than girls, because you have that foreskin that encapsulate bacteria, and you have new moms who don't, you tell them you need to pull it back and clean around it, but they're like, I don't want to touch it, and so then that bacteria has a warm, moist place to grow. So what's going to happen? Going to travel up the urethra and cause bladder infections. Now, if the boy's circumcised, you're less likely to have an infection. It's mainly in those uncircumcised. So yes, a baby girl's urethra is shorter, but uncircumcised males have a breeding ground for bacteria if they're not cleaned properly. So adolescent girls, especially those that are sexually active, are going to be at higher risk of developing a urinary tract infection. So our most common type of bacteria we're going to see is E. coli. 85% of your infections are caused by E. coli. So give me some reasons why you may see E. coli, especially in girls. Improper wiping, okay? That's why if you have a little girl, it's very important to teach them you wipe front to back, okay? Not back to front, because then what are you doing? You're introducing that fecal matter, which has bacteria. Most of us carry E. coli in our system, and they're going to introduce that to the bladder, okay? Or the urethra, that will introduce it to the bladder, okay? Other organisms that you can think of that could cause a UTI, you have the Proteus, the Enterobacter, the Cytobacter, Pseudomonas, Klebsiella, Staph, and Enterococcus. So you don't have to know all those different ones. Just remember, your most common one you're going to see is E. coli, okay? UTIs are more prevalent in females because of the short urethra. So in young girls, it's about 2 centimeters long. So think about 2 centimeters. So we pretty much can say from one knuckle to the next on most people is a centimeter, okay? Or we do our finger breaths. Remember when we're doing OB, we consider that about 1 centimeter. So 2 centimeters, that's pretty short, okay? Uncircumcised males, especially these less than 3 months of age, are going to be a big risk. Other contributors is urinary stasis, urinary reflux, where that urine refluxes back up into the kidneys, dysfunctional voiding, pregnancy, teen pregnancies, constipation, and catheters, okay? We see the catheters a lot in our elderly. We don't see it in our young kids, but if a child has a urinary development problem at birth, they may have to have a catheter. So some other causes we're going to see is antimicrobials, tight clothing or diapers, and poor hygiene. So infrequent diaper changes. You know, those little kiddos that mom changes the diaper every 8 hours because maybe they can't afford diapers. And so what is that warm, moist diaper? It's a breeding ground. That bacteria is going to grow, okay? Inflammation, so it can cause, or if you have vaginitis, and okay, everybody's like, why is masturbation on here? Toddlers masturbate, okay? It's part of their childhood process. They learn their bodies, they touch their areas, and it feels good, so what are they going to do? Again, they're going to do it again. So that's when you have your little boys like, don't touch your penis, please. Keep your hands out of your pants while we're in public. You know, you just have to teach them the appropriate time to keep their hands in their pants and not, okay? So what are they doing when they have their hand there? They're introducing bacteria, okay? Pinworms. Little kids play outside in the dirt. You have pets that are in the dirt. And what happens? They put their hands in their mouth, they get those pinworm eggs, and they get pinworms, okay? Bubble baths for girls especially. Certain types of soaps, shampoos, hot tubs, whirlpools, and of course, sexual intercourse. So what is our clinical quiz? Most common UTI bacteria. What is the most common UTI bacteria? E. coli, good job. That's probably pretty important to remember. Ooh. Okay, so clinical manifestations. What are we going to see in these kiddos? Okay. So newborns and infants, it's like a GI tract disorder. Okay. So they're going to have failure to thrive, feeding problems, vomiting, diarrhea, abdominal distension. Infants and toddlers under 2, you're going to see more likely fever, irritability, lethargy. What's lethargy? Right, they just lay around. They don't do anything. They sleep extra. Poor feeding, vomiting, diarrhea. In newborns, you're going to see fever, hypothermia, jaundice, tachypnea, and cyanosis. You can also develop sepsis, okay, if it's not caught quick enough. Why would sepsis be possible in a newborn? Right, they don't have a developed immune system. They don't have that immune system to fight off that bacteria like if they had already been exposed to some bacteria and had antibodies built up, okay? So babies can go septic very quickly, okay? So diaper rash is common with UTIs. Irritability, they're going to be squirmy because it's uncomfortable. Think about if you've ever had a UTI. They're going to sometimes void frequently or infrequently, depending on how their bladder reacts. And again, they could have jaundice. So in children, you can see enuresis. Does anybody know what that is? It's basically bedwetting, incontinence, okay, bedwetting. Daytime incontinence in trained children. Fever, foul-smelling urine, dysuria, urgency, and frequency. I encourage you to learn all of the terms related to the urinary tract, like dysuria. Okay, what's dysuria? Painful urination, okay? They're not going to say on your NCLEX, this person's complaining of painful urination. They're going to say, this patient's complaining of dysuria, okay? So I encourage you learn those terms, okay? Those are some important terms to know because, you know, your urinary tract, that's a lot of the things you're going to see, okay? They're going to complain of abdominal pain, flank pain. So a lot of times people first immediately think, oh my gosh, they're having appendicitis, okay? Because they're going to kind of have some frontal pain down where that bladder is, but then they're also going to have flank pain, okay, where those kidneys are, okay? And you might see hematuria, blood in the urine. Again, that's another word that's important to know. Boys may have dribbling, so after they're voiding, maybe they didn't completely void, so they'll kind of dribble after on their pants. Or they have to strain, girls and boys, to void. Or they have a decreased force, like they're not able to fully empty their bladder. So obtaining a urine specimen. So I didn't add this in there because I just found it last night, so I was going to tell you about it after we went through this, but I'm going to tell you first. It's called quick wee pee. So it's a study they did in Australia where they were trying to find a better way to collect a urine specimen on a baby. Okay, so what do we usually do? What do we use? A little pouch. We don't always use a catheter. We want to do a clean catch first if we can because we don't want to traumatize the bladder. Okay, so we have like a little bag that has a little sticky thing that, you know, you put over the penis or you put over the vaginal opening, and then that bag is supposed to catch the urine. So you put a diaper on still, but you do it loosely so that bag can fill up. Okay, and then you go check every 5-10 minutes, see if the baby voided, and then sometimes they void, but does it go in the bag? Not always, or you don't have enough. Okay, so nurses have been struggling with this for years, and so this Australian college kind of did some different studies, and they found that if you take a newborn, you would take their diaper off, and you get cold water saline, dip like a couple cotton balls and just use a forceps to hold the cotton balls, and you gently kind of put a little bit of pressure where that bladder is and rub with that cold water. Within 5 minutes, that baby will void. And so I thought, well, that's really interesting. It was a study done in 2017, and I was like, that's something I've never heard of. I'm like, I'm going to have to try that next time I have a baby. I got to catch a urine on. So most of the time, we're going to do a clean catch, okay? We want to do a clean catch because we don't want to introduce bacteria with a catheter. Of course, when we catheterize, it's a sterile procedure, but is there still a risk of introducing bacteria? Yes, okay. So the other possible way, again, is catheterization, the urine collection bag. They may even do a suprapubic aspiration where they stick a needle through the abdomen into the bladder and just draw back. Okay, it's a pretty small, thin needle. Think of like if you've ever seen a spinal needle, how thin and small they are, kind of about the same size, okay? And then those little minute holes just kind of seal back over on their own. You don't have to go in and like suture anything. Catheterization and suprapubic aspiration are the best ways to obtain a good specimen for children 2 to 24 months. Clean catch is best obtained from girls by having them sit on the toilet backwards, and you can use a hat, okay? Allows labia to be naturally separated and decreases that contamination. So other diagnostic tests you might see in childhood, CT or an MRI, just like adults. Cystoscopy, does anybody know what a cystoscopy is? Okay, it's for the bladder, but what do they do? It's a scope. So it's a metal scope. It's about 15 to 16 French, pretty small, that has a light and a camera on the end. When I worked in a couple of OBGYN offices in Tulsa, we did them in the office. So it's something that you don't necessarily have to do under sedation. Now, child, they're going to. But you put the scope up in there and you can look at the bladder. A lot of times they'll fill the bladder with normal saline, let the patient sit, have them void, and then they go back and look again, and then they can see if they have interstitial cystitis, which is actually not really an infection, but it's caused by irritants like acidic foods. Then the lining inside the bladder will actually bleed from all those little capillaries. And so it's really neat to see one done. Ultrasounds of the bladder. They may do intravenous pyelograms, so that's where they're going to introduce a dye and look at those kidneys. The voiding cystourethrogram, so that's where they're going to actually have them void. Some labs are going to do BUN, creatinine, UA, and a urine culture. Most doctors will order a UA to reflex if there's like abnormal, okay? So that way you don't have to call and get another order from the doctor. Most of the time they're going to deal UA with reflex. So if there's tons of WBCs, then they're going to automatically reflex that to culture, because then they don't want to have to call and say, okay, it's positive, can we culture, okay? Quiz. Signs and symptoms of UTI include, this is just one, In children, what are some signs and symptoms? Correct. Your most common is fever and flank pain. Okay. Nocturia, that's just getting up and peeing at night. Okay, so that's not the incontinence, that's that enuresis. Polyuria is just peeing too much. Okay, and then urinary continence means you're avoiding normally. Okay. Good job, guys. Okay, so treatment. Our goal is to eliminate the current infection. So we're going to use antibiotics. So I'm going to say the brand names because all these generic names I can't ever say. Y'all hear me stumble over my tongue all the time. So Bactrim is the most common, along with like your microbid or macrodam. Okay. Amoxicillin, Keflex or cephalexin, and Fortaz. Fortaz isn't one I've really seen used much, but I don't work with pediatric patients very often. I see more of that macrobid, macrodentin, and Bactrim. Of course, it's going to depend on allergies. You know, some kiddos do have allergies, so that's why it's always important to ask mom. And then also, it's important to educate parents. So if a child who's 6 months old comes in at a 4 o'clock in the afternoon appointment, they diagnose that child with a UTI, okay? Mom goes to the pharmacy doesn't get her the medicine until 8 o'clock, and that baby goes to bed at 8:30. Do you think she should start the antibiotic that night? What is the risk? It's a brand new antibiotic. She's never given this baby this antibiotic before. Right. You don't know if they're going to have an anaphylactic reaction. So if you're going to give the baby the medicine at 8 o'clock, they fall asleep at 8:15, you go lay them down. If they have an anaphylactic reaction, would you know it? No. So that's why it's important in children, you have to think these things through and know how to educate the parents, okay? Even though, yeah, the child's sick, unless she got there at 4, got her medicine at 6, she knew baby wasn't going to go to bed till 8, she has plenty of time to watch that baby for 2 hours. But if she's going to immediately give the baby medicine and lay it down, not a good idea, okay? She needs to wait till the next morning or sit with that baby until 2 hours, 3 hours has passed and she's seen to make sure they don't develop a rash, okay? Now, will a child have a reaction with antibiotic the first time they would get it? Not necessarily, okay? Some kiddos can receive a full dose of an antibiotic, but may not have their allergic reaction until their body is introduced to it again, the second time, okay? They may take a full series of amoxicillin, have no issues, and then the second time, a month later, when they get that ear infection again, doctor prescribes amoxicillin, and then they go in, give it, and they have a reaction, okay? Because their bodies are first introduced to it, and then it's like, oh my gosh, we don't like this. The next time is when you may have that reaction, okay? That's pretty common. Identify contributing factors, okay? Is it because the diaper's not being changed often enough? Is it because the child's not wiping properly? Prevent urosepsis. Again, little kids are going to be, especially babies, are going to be more prone to becoming septic faster. And preserve renal function. So, prevention of urinary tract infections. So, we're going to do perineal hygiene, okay? Teach mom and dad how to teach the children. Avoid those tight-fitting clothes or diapers. You're going to check for vaginitis or pinworms. You're going to have them void frequently. Avoid straining. Increase fluids. And so, what is one fluid that we kind of associate with UTIs? Cranberry juice. Why? It naturally soothes that bladder, okay? It also creates the urine to be more acidic. So if the urine's more acidic, it's going to kill that bacteria, okay? So cranberry juice really does help with urinary tract infections, okay? So it just helps to kill that and also helps to reduce the more growth of that bacteria. Avoid constipation, okay? Think about what constipation would do. If they're constipated, where's that urethra come out? close to the bowels, right? So if you're obstructing the ureter or the urethra a little bit in that flow, then that can cause that urine to sit and grow bacteria, okay? So how are we as the nurse going to manage this? Okay, first we have to assess the patient. So recognize some signs and symptoms. Again, what do you remember seeing some signs and symptoms we talked about earlier? Abdominal pain, flank pain, dysuria, smelly urine, yeah. Distension, okay, you're not voiding all the way. Possibly, especially like we talked about that dribbling in the older kids, especially boys. Are we going to run a fever? Probably, especially if it's pretty good bacteria growing, okay? Obtain a clean catch for lab if possible, okay? Diagnosis of that we would use would be impaired urinary elimination, urinary retention, ineffective health management by the family, because again, what do we talk about? Sometimes these are caused by poor hygiene and properly changing the diaper, okay? Risk for fluid volume deficit. So what are some interventions that we're going to possibly implement? Education. Medication, okay? What type? You said antibiotics. What else is another medication you might use? Pain medication, Tylenol, ibuprofen for the pain and the fever, okay? Okay, so yeah, we're going to implement those tests, you know, that the doctor has ordered. What about, we want to increase fluid volume, right? Because we want to clear out that bladder of all of that excess bacteria. Do you think it'd be important to monitor their I&O? Yeah. And again, you said education. So then how are we going to evaluate? So you've got a 4-year-old that's come in 1 week post UTI. What are some easy questions? You know, you're going to ask mom and dad. They're going to tell you. But what are some easy questions that you, as a nurse, can ask the child? Okay, we got to think 4-year-old, child level. Okay, so what are some easy questions that you could ask that child?
How much water?
Okay, how much water do you drink every day? And if she has like a little, you know, my daughter carries around like a Bubba flip top, you know, and she says, I drink 2 of these a day. Then you can look at the ounces and see how many, okay? Do you hurt when you pee, right? Because most 4-year-olds are going to understand the term hurt, okay? What else?
Part of your body hurt.
Right, does any other part of your body hurt? Right, because we're going to think about tummy, back, because they're not going to know what flank pain is, but they might say, oh yeah, my back hurts right here, okay? So you've got to think, when you're talking kids versus adults, you got to think of terms they can easily understand, okay? Because yeah, you're going to interact with mom and dad, and they're going to probably give you a lot of information, but it's also important to interact with that child and get that information from them as much as you can, okay? Quiz. What factor indicates that a urinary tract infection is present? Which is the most correct answer? Okay, so this was one of those tricky ones because most of these answers could be correct except acidic because we want it to be acidic. So frequent urination could be a sign, but we're asking what indicates that a urinary tract is present. What's the most correct answer? Okay, so again, when you're looking at those test questions, break them down like we did. Talk about it in your head. Write it down on your white sheet of paper. That's what it's there for. You know, in your test taking ability, we give you ability to highlight, to kind of mark off, you know, so break it down. This is asking what factor indicates. What's the only thing that can really indicate a UTI? A test, right? I mean, we can ask for symptoms, and that's going to give us an idea that it potentially could be a UTI. But the only thing that we really know for sure that's going to indicate is bacterial growth on urine specimen. job. Okay, so structural defects. So we're going to go over all 5 of these, okay? So some kids are born with these structural defects of the urinary system, okay? This is something that can happen and you're going to see at birth. Sometimes these can be caught in ultrasound, but not always. So extrophy of the bladder, okay? So this is failure of the abdominal wall to fuse in utero. It includes the ventral wall of the bladder and the underlining structures. Okay, so you're going to see the bladder basically on the outside, or an opening into the bladder on the outside. Okay, this is found on page 1368 in your book. So that urinary tract is exposed. Okay, so that bladder is exposed, maybe the urethral opening is exposed. It can be different variations. So you're going to have a constant seepage of urine. There's a chance that that pubic bone may be separated. It may not be fully connected with that little cartilage plate that you see in the front. Females, it's usually present with a split clitoris. Males have a little stubby penis, flat glands, undescended testes, and likely are going to have also inguinal hernias. Where are inguinal hernias found? Groin. Down kind of like at the bend of those legs. That's inguinal. Okay? So these kids, tell me some risk factors this child's going to have. Huh? Infection. Okay, they're going to be incontinent. So if they're incontinent constantly, you have constant seepage of urine, think about tissue integrity. Skin breakdown, right? Urine's acidic, correct? That mucous membrane, inner bladder tissue, is going to be very susceptible to that acidic urine constantly sitting there, okay? So you're going to have to educate mom and dad on how to properly change diapers, frequently changing diapers until it's able to be repaired, okay? So what are some treatments that we can do? So we're going to do preservation of the renal function, hopefully. We're going to hopefully attain urinary control. We want to do surgery. We want to hopefully reconstruct this baby's urinary system if we can. We're going to prevent UTI, so that's going to be educating the parents on proper diaper changing, keeping that area from moisture and that urine growth or bacteria growth in the urine. You're going to preserve that external genitalia, hopefully with sexual function if possible. It used to require multiple surgeries, and now we've been able to perform one single stage correction in infants. And it has varying degrees of success because it's going to vary on how severe the deformation is. A multi-stage repair involves bladder being closed during the neonatal period within 1 to 2 days of life, and then going back and continuing closing things up. So nursing management, how, as we, the nurse, want to help manage the care of this baby. Okay, so immediately when that baby's born, we're going to cover that area with plastic. Okay, plastic wrap if we have a Ziploc bag, kind of like we would do with our pretermers. Okay, because we want to keep that one from drying out because we don't want it to. We need it to be somewhat moist. Okay, we want to have tissue integrity. So you want to keep the wound and pelvis immobilized to promote healing. You are going to monitor the output and signs of infection before and after the procedure. So what does output tell us? Before or after a procedure, what is it going to tell us? Right, if they have a good flow, they didn't close up the ureter completely, right? Because think about how teeny tiny a baby's system is going to be, okay? So interventions, we're going to provide skincare. We're going to promote healthy habits for mom with changing diaper, promote skin integrity. Encourage that parent-infant bonding. Because do you think the mom and dad are going to be a little scared? Yeah. Here's your exciting moment. Everything's wonderful. This baby comes out and immediately something's wrong. So they're going to be scared. They're going to see that and think, oh my gosh, I'm going to hurt the baby if I hold on. But no, we want to still continue that bonding. Okay. So we're going to promote them bonding as much as possible with baby.
So could this affect their reproductive like later on?
Later, possibly, yeah. You're going to try to maintain sexual function if possible, but like it depends on the severity. So think about a female, that bladder's connected to her uterus. Okay, so those ovaries and fallopian tubes are in that area. So there could be a malformation in that part too. Quiz. A young child is diagnosed with vesicular reflex. The nurse should know that this is usually associated with, oh, I put this in the wrong spot, guys. Yes. Reflux. Reflex. Think about reflux. What's reflux? What we call the reflux. Good job. So I would have thought obstruction too, and possibly could be if they have kidney stones, okay? But recurrent UTIs, because what happens when you continue to have infections in tissue?
It diminishes the vessel.
Right, and scarring occurs, right? So if scarring occurs, then that tissue is not going to work as well and promote that moving down of that urine, and so you're going to have some refluxing. I might have created this in my car while I was driving down the road yesterday. Actually, no, I did this like last Tuesday, but I thought I had looked in. Okay, hypospadias, epispadias, okay? So this is important as a nurse if you work in OB or newborn nursery, that when you're doing your full assessment after delivery on little boys, you have to pull that foreskin back and find where that urethral opening is, okay? That way especially if it's in the evening or afternoon, because sometimes those pediatricians, you can call and let them know baby's going to be there, but they're not going to come in immediately, as long as baby's healthy. But if you let them know something's wrong, then they're going to come in. Now, if it's the urethral opening, usually it's not a problem. That's something that's going to have to be fixed later, okay? As long as they're voiding normally. We don't have any issues, okay? So this means that the urethral opening is located below the glands or above the glands, okay? So in this one, you can see that it's below. So which one is that? Is it epispadias or hypospadias? Hypo, right. Think of those words, break them down, okay? So the most important thing to remember on these babies is do not circumcise, okay? So they will use that extra foreskin that's there to help with grafting, okay? So that's, again, important why you as the nurse assess that. Because if mom's like, oh yeah, I want my baby circumcised, nobody really assesses, which most pediatricians are going to look, but he gets circumcised and now we have an issue, okay? I'm sure there's other ways we could do it, but if we can use their skin, it's going to take better. So your prime time for surgical repair is about 6 to 12 months before development of body image. Of course, you don't want to do it when they're little guys and older, because then that's going to be scary. They may also give testosterone for a short period of time to increase the penile size prior to surgery, because what is that going to help that skin do? Grow, right? It's going to help it grow, so that way they will have excess tissue to be able to use to repair it, okay? So what is the nurse going to do? So we're going to address those parent concerns, okay? We're going to be encouraging, okay? This is not any big deal. We see this often. This is a common surgery and problem that we see. You don't want to give them false hope, but don't let them worry over it, okay? Educate them. You want to protect the surgical site from infection or injury, follow hospital policy for care. So if you are on the floor, surgical floor, and you get a baby back after they've had a repair, you have to keep that incision clean, dry, intact, just like any other surgical site. Is that going to be easy on a little boy that's pee in a diaper? No, because they're not always going to catheterize them, okay? Because again, they want to not introduce bacteria and cause further infection. Ensure adequate fluid intake and patency of the stent that's placed. So on page 1370, there's more information about the hypospadias and epispadias, okay? So this is the vesiculorectal reflex, or VUR, okay? This question was supposed to be further down. So it's a retrograde flow of bladder urine into the ureters, okay? So it's meaning that urine is going up instead of down, like it's supposed to, okay? So reflux of urine from increased bladder pressure up ureter and into the renal pelvis. It ranges in severity, so you're going to have grade 1 through 5. Reflux prevents complete emptying of the bladder, and it results for bacterial growth. Okay, you have urine that's sitting there, it's a warm, moist, dark area, and that urine is going to be a breeding ground for bacteria. So this can lead to infections such as a UTI or pyelonephritis. So what is pyelonephritis? Kidneys. Okay, think about your pylons in your kidneys. So pyelonephritis is infection in the kidney. So that's the medical term for kidney infection, okay? So what are some causes of VUR? So you have neurogenic bladder. It causes high pressure buildup. So you're going to see this in children with like spina bifida, okay? They're not able to void appropriately because they don't have the sensation to void. And so that urine is going to build up, and if the bladder's going to expand too much, and then where's it going to go? The only way it has to go is up if they're not voiding. Infection. This can be a cause for the VUR, and so this then can lead to pyelonephritis. Or congenital anomalies of the ureters. Okay, where are they placed? So how are they going to diagnose this? They're going to do avoiding cystourethroplasty. So they're going to contrast and dye if injected into the bladder through a urethral catheter until the bladder is full. Films are taken before, during, and after voiding. You visualize the bladder outline of urethra, reveal reflex of the urine into the ureters, and show abnormalities of the bladder emptying. So treatment and nursing management. How are we going to take care of this as the nurse? Okay, what's our role? So long-term antibiotics for prophylaxis of UTIs, okay, because they're going to be at higher risk of developing those UTIs because they can't fully empty that bladder and that urine is able to move back up. So ones that you might see is like Bactrim, the Macrobid, Macrodentin, amoxicillin again. Those are the ones you're going to see. Surgical intervention to correct the defect. So you're going to have reimplantation of the ureters. They might do a deflux procedure, okay? It's a bulking agent to change the angle of the ureter. It's injected beneath the mucosa of the uterovesical junction to change the angle of the ureter during cystoscopy. So how are we going to manage this care? So catheter care and management. So what do we do with catheter care and management? Think about it. What do you do for adults? You're going to clean it. You're going to keep it clean. You're going to assess for patency, right? Because if you're not having urine come out, you may have a kink in the tube. You can have a kink in the Foley itself, or you can have buildup of sediment or mucus in the Foley. Okay? Urine may be bloody initially, but should clear up within 2 to 3 days. You're going to do IV fluids to help maintain adequate output. Administer antibiotics and antispasmodics, because that bladder, anytime you mess with the bladder, you get bladder spasms. Okay, it's a muscle too, just like anything else. and it can kind of spasm. That's what a lot of people feel when that pain or discomfort when they're having a UTI. It's that bladder actually kind of spasming. So when are we going to discharge? When we go to discharge, usually you're going to do removal of the catheter and make sure they can void before they go. You're going to teach about the antibiotics administration. Yes.
When there's bladder spasms, does that mess with the sphincter or just the bladder itself?
Usually just the bladder itself, but it can, like it, because you think about your sphincter, it's part of that muscle. So it can affect it to where they're not voiding completely. But most of the time, the spasms, you just want to reduce those spasms, especially if you've done a repair, because you don't want to move that repair, basically. So, but it can, if you're having a UTI especially. You're not able to always void completely if you're having spasms. And they're very uncomfortable. So we're going to teach about the antibiotic administration. Okay, tell mom and dad how often, how long they're going to do it. Teach them about signs and symptoms of infection, what to look for. And they're going to have to avoid active play for about 3 days. Quiz. What is the priority intervention in a neonate with exstrophy of the bladder? Correct. We're going to cover the exposed bladder with plastic wrap, okay? Because we're going to help with that integrity of the tissue. And we aren't necessarily going to have to catheterize because that urine's flowing freely from the abdominal wall itself, okay? Good job. So now we're going to talk about prune belly. So in your books on page 593, there's a picture, okay? So these babies have, it sounds just like what, they have abdomens that look like, kind of like pruny. So think of a prune, you see all those little wrinkles and crevices. Or think of a Shar-Pei dog, okay? A Shar-Pei dog has, when they're puppies, they have all those little grooves, okay? So prune belly babies are babies that have an abdomen that does not have a wall, okay? So there's no muscle tissue there. So all that skin is just kind of like pruned up, wrinkled up. Think about all those wrinkles, okay? So it may also, you may also hear it called Eagle-Barré syndrome, but most people call it prune belly. It is a congenital defect. The abdominal muscles fail to develop. Skin covering that abdominal wall is thin. Okay, so think about your skin tissue, how thick it is, and it resembles the wrinkling of a prune. Other characteristics that go along with this, because you're like, why would a prune belly be in urinary? And this is why. So usually they're going to have urinary tract anomalies or urethral peristalsis, so that urethra is not going to move like it should to help pass the urine out. Enlarged bladder, high risk for recurrent UTIs, the VUR, bilateral cryptorchidism, so they don't have, those testicles are not distended, okay? It usually can be diagnosed prenatally in ultrasound. So this is something that moms are usually not going to be surprised about. Following delivery, surgical reconstruction of the abdominal wall and correction of the genitourinary defects occurs. So as a nurse, what are we going to do? We have to think ABCs. Airway, which is the most important. Are these babies going to have a problem breathing? Yes. Okay. Think about your abdominal muscles. Okay. What are babies? Belly breathers, right? When you see those newborns, their bellies are just going up and down. Okay. Those abdominal muscles help their lungs to expand and open along with their diaphragm. So if they don't have abdominal muscles, do you think they are going to be able to breathe properly? No. So you're going to have to think, if you know you have a mom coming in who's delivering a baby that has the Eagle-Barré syndrome or prune belly, you're going to have resuscitation set up. You're going to be ready to help that baby breathe, okay? You're going to also be responsible for pre-op and post-op care for baby. And think about the psychosocial support for the family, okay? Because again, this mom thankfully may have already been prepared at delivery, but they're not prepared until they see that baby, because it's going to be shocking, okay? So think about ways that you can help encourage and educate them.
So that muscle never grows back then?
Huh?
That muscle never grows back then?
No, muscle, no. So what they do is they usually, with reconstruction, it just depends on what's there, on how they can reconstruct, but yeah, you can't regenerate muscles that aren't there. Like usually with your muscles, if you go and you work out, you rip them, then they build up, and then over time, if you don't, they go deflated again, but then you can build those up. But if those muscles aren't there, you're not going to regenerate them. It's usually pretty good with reconstruction, as long as you catch it and they have it and you get the airway, make sure they're breathing. You're probably going to have some assistance until they get older to be able to use that diaphragm properly and not those belly muscles. Yes, ma'am. Well, without reconstruction, it's probably, that baby's probably they're going to have to have long-term assistance again and they're going to have to be very careful, because that the only thing they have there is that skin tissue, okay? And that skin tissue is very thin. So usually there's going to be some way, we do have, think about those meshes that we've used in repair of the vagina and things like that. Well, now we know a lot of those can cause other problems, but I'm sure, I didn't do too much research on what they would do besides the reconstruction. But that I will look and I'll post some articles, okay? So Wilms tumor, this is one, I think I had an NCLEX question over Wilms tumor when I did my RN NCLEX. So it's called nephroblastoma, and this is on page 1307 in your book, okay? It's an intrarenal tumor. It's a rapid growing abdominal tumor in children. It doubles in size in about 11 to 13 days. Okay, so this isn't over months, this is over days. Most children are diagnosed between the age of 2 to 3 years of age, and most children have no other abnormalities, however, may be genetic and associated with genitourinary anomalies. So there could possibly, in some children, you're going to have no other sign, okay? So they're asymptomatic, painless swelling, usually on one side. It's a mass in the abdomen. Okay, all of a sudden mom called the doctor up and said, my baby's, my little kid's belly is kind of swollen. They'll bring them in, okay? So it's a firm, non-tender mass. And parents are usually going to discover it like maybe when they're tickling them, playing with them, maybe bathing them. They're going to notice all of a sudden there's a bulge there, okay? So the biggest thing with these Wilms tumors is you have to be very careful with them, okay? They may have signs and symptoms of malignancy, like weight loss, anorexia, anemia, or they may have no symptoms at all. They could also have hypertension, and this is related to renal damage, okay? So think back on how your kidneys and everything works. If they're not working appropriately, then you're going to have hypertension. Could also display symptoms, as well as hematuria and abdominal pain, okay? So staging and prognosis of the Wilms tumor. So in your book, if you look at box 5070, you'll see how they stage those Wilms tumor, and you don't have to know it for the test, okay? They do have a high survival rate. So treatment for this is surgical. You're going to remove the affected kidney and adjacent adrenal gland. They're usually also going to have some kind of chemotherapy. They need to keep that tumor encapsulated, okay? Because these are cancerous tumors. So, one of the most important things that you have to teach parents or as a nurse, if you have a patient who comes in, mom's complaining of they've got this big bulge on one side, should not palpate, okay? You may touch lightly just to feel the size of the bulge, but you do not want to palpate firmly. Because if that ruptures, you're going to spread those cancerous cells throughout the abdominal area, and that cancer can spread, okay? So, again, they're going to use chemotherapy. If both kidneys need to be removed, then dialysis is done until they can do a transplant. Radiation is going to be used for stages 3 and 4, or if there's metastasis, if it has ruptured and it has gone to other places, and the most common place it's going to go is to the lung.
Does this only happen on one kidney or both of them?
Well, it can affect both. Usually you're going to see it on one, but it can affect both, okay? So what are we as a nurse going to do? So we're going to have to develop a plan of care using our ADPI, okay? Assessment, diagnosis, intervention, okay? Our plan, intervention, and then how are we going to take care of that? So, assessment, we're going to obtain a good history and description of the child's symptoms. We are not going to palpate the abdomen, okay? You might measure it to see the size, but we aren't going to palpate forcefully. Monitor vital signs, okay? Especially the blood pressure. Again, it's to do with the urinary system, so they could have hypertension. Diagnosis, so they're at risk for infection or inadequate defenses, because when kiddos have cancer, is their immune system usually working 100%? No, usually that immune system's fighting against that abnormal cell, and so it has depleted it. Risk for injury, okay, so we don't want them to fall. We don't want them to get hurt, because if that cancerous tumor opens up, then reseeding can occur. It can spread to other parts of the body. Decreased tissue perfusion due to cardiac and urinary systems, such as hypertension. So that mom and dad are going to be scared. So you're going to have caregiver role strain, because it's a pretty severe illness. You're telling your child, the doctor's telling this parent that their daughter or son has cancer. You want to protect that other kidney. So you're going to have impaired home maintenance, because, again, we don't want them to play. So we need to assess the home. What does it look like? We need to create a safe space for them until they can have surgery, okay? Planning and implementation. We're going to teach importance of decreasing rough play while tumor is present, since it could rupture. And then we're going to evaluate, okay? So, again, post-surgery, our other important things are like that cough, deep breathe. You're going to look at the fluid and electrolyte balance, vital signs. They may have to have an NG tube placed. You're going to measure the abdominal girth, because you want to make sure, is it growing any larger? Again, you want to have simple play, not rough play. So think of board games, drawing, painting, coloring. What are things they can do that they're not going to have to be too physically active for? Okay. Quiz. What would the nurse not want to do to a child with a Wilms tumor? Correct. Palpate the abdomen. Pretty important to know. Okay. So now we're going to go to enuresis. Okay. So this is in your book on page 1373. It's repeated involuntary voiding by a child old enough to control bladder, age 5 to 6. It may be nocturnal or diurnal. So it can be during the day, but you're most likely going to see this during the night, okay? It can be categorized as primary or secondary. Primary, never had a dry night, not associated with stress or psychiatric cause. Okay, so this is something the child, even though it's potty trained during the day, has to still wear a pull-up or a diaper every night because they're gonna pee the bed no matter what. They haven't got that control enough of their bladder to not pee at night on their own. Secondary has been reliably dry for at least 6 months, and then all of a sudden begins bedwetting. So this can be associated with stress, infection, sleep disorders. If you have a kiddo that maybe is like 3 or 4, and you know they've done really well, they haven't wet the bed, and then all of a sudden a new baby comes, they start wetting the bed. They're a little stressed. Someone new's in the house, okay? Maybe something has happened. Maybe they're being abused now. Maybe they're just scared of going to school because they don't like being alone or without mom and dad. So secondary is going to be there's an outside cause. Usually it's a psychosocial something, okay? It can be associated with infections also, so that's something you would want to test for. So primary, you're going to look at how mature is that bladder. Why aren't they able to control the bladder through the night, but they can through the day? Okay. I've known someone that when he was a small child, the doctor thought maybe it was the size of his urethra. And so he had to have a surgery where they dilated his urethra. Didn't help. So that wasn't the reason. Okay. Could be maturation of the bladder. Is the bladder not fully mature? Because they have a small functional bladder. Okay. And sometimes it's just training that child, getting that child up 1 or 2 times a night to get up and go to the bathroom. They also have different systems. They have pee pads that you put on that, like, once it senses the urine, it sets off an alarm, wakes the child up so they can get up and try to go to the bathroom. You know, there's all kinds of things people have created to try to help break this system of urinating in the bed. So what are we going to do? We're going to obtain history, family history and structural history, any other anomalies in the urinary system they were diagnosed as a child. Is there any family history of bedwetting, and what age did it stop? Because you can kind of see a trend in families. Family management, how does it affect the family? What happens when it happens? So who changes the sheets? How is that child treated? Do they get punished for it? Are they blamed? Any remedies that they have already tried. You're going to assess, when were they potty trained? When did they start training that child? How effective was it? Are there any, has a child ever been dry during the day and or night for an extended period of time? You want to see, again, if it's primary or secondary. How often does the child void or have a bowel movement? Does the child have a history of constipation? So some risk factors that can be associated with enuresis is diabetes, signs of polyuria or polydipsia, okay? Or UTI, does a child have frequency, urgency, or burning with urination? So treatments, you're going to limit nighttime fluids, so you're going to cut them off. They're not going to get that cup of water before bed, like a lot of kids try to get, because they don't want to lay down. They'll say, I need some water. Whose kid does that? Okay. Bladder training. Have they tried bladder training? Have they used the alarms, the pee alarms? Have they done medications? Okay. There's an antidiuretic they can use. Desmopressin, oxybutynin, which is an anticholinergic, antispasmodic. Okay. Imipramine. This is it is an antidepressant, but it helps to help reduce those spasms. Quiz. Which of the following is true about enuresis? Which do you think it would be? So usually it's outgrown, okay? So even though a child may start bedwetting due to a new stressor in life, it usually is resolved. Usually as they get older, it's outgrown. They don't continue to do it, okay? So, good job. So some other renal disorders we're going to talk about after we come back from break, okay? So it's 9:37. We'll come back at 9:50. So there is a college out there if you guys want to talk to them. They do RN to BSN, and you actually get a little bit of credit for your time here at SCC. So, let's take a break. Recording. Okay, so now we're talking about renal disorders. So we have two different ones we're going to talk about. Of course, there's others that we could go over, but the main two we're going to talk about is nephrotic syndrome and acute glomerulonephritis. Okay, so it's inflammation, or sorry, acute glomerular nephritis. Come on. So acute glomerular nephritis is inflammation of the glomeruli of the kidney. Okay, so you can have minimum to severe. This can be found on page 1377 in your book. This is also known as AGN. Okay, so your common symptoms that you're going to see is oliguria. What does that mean?
A little bit.
Right, minimal amounts of urine. So oligo, oliguria means little, okay? Edema, hypertension, proteinuria, hematuria, okay? Most cases of AGN are post-infectious, okay? So this is after they've had a severe infection. Can be related to pneumococcal or group A beta hemolytic streptococcal. Okay, that's your most common. So this child could have had strep throat, a severe strep throat. It affected the kidneys, the glomeruli in the kidneys, and so now you have AGN. Prognosis, you'll recover with immunity basically. So once you've had this, you're not very likely to see it happen again in the same patient, okay? Some do develop chronic nephritis, okay? So clinical manifestations you're going to see. So you're going to see periorbital swelling or edema, so around the eyes of those kiddos. Anorexia. They're going to have dark colored urine. So think about like Coca-Cola, how dark and brown and almost black it is. Decreased output. The edema can spread to the legs and abdomen during the day when they're up. Mild to moderate blood pressure elevation. So you can see it get as high as 200 over 112, okay, on these kiddos. And we know kiddos' blood pressure usually runs lower than adult, right? So 200 over 112 is pretty high. So what are some signs and symptoms we need to monitor for if this child has hypertension? Think about your hypertensive patients. What are some signs and symptoms they complain of? Headache? Okay, swelling. We've got the swelling.
Dizziness.
Yeah, dizziness. How about visual changes? Blurry vision, that's a very common complaint, right? Vomiting. You might even see a decreased level of consciousness. They may be confused, okay? So just remember when you're taking these tests for us and on NCLEX, don't just think about symptoms. Sometimes you have to, or about specific, okay, you're asked what does AGN possibly cause? Hypertension. But then what if it says you have a patient that presents with a history of UTIs or a history of a severe strep throat, strep A infection, and now has dark colored urine, diagnosed with AGN, but also has blurry vision, headache. What is it? What's that patient suffering from? Okay, so think through those questions. If there are other symptoms, you're going to also see some proteinuria, hematuria. So you're going to think about your ABCs again. Okay, so with edema and swelling, you're going to have possible issues with breathing. Okay, airway issues, breathing issues, because that fluid's not only going to go to the outer tissues, but can also go to the lungs, correct? So circulation issues. They're going to have a fluid volume deficit. So treatment and management for AGN is monitor the labs. So think of some labs that you're going to probably do. Name them for me. BUN, creatinine, CBC, CMP. What's another one? Right. You're going to do your analysis and then possibly culture and sensitivity if it reflexes. You're also going to check your ESR, your sedimation rate, because of that swelling. Okay.
Do the GFR rate?
No, ESR.
Would you check the GFR rate too?
You possibly could, yeah. So hemoglobin and hematocrit's also important because if they're having hematuria, they could initially, if it's been long term, they could have a low H&H. The fluid volume excess will also make them look anemic. So think about our pregnant women who have that increase of fluid volume in pregnancy. They're not truly anemic. They have enough red blood cells, but they have that extra fluid, right? So if these kiddos have extra fluid in their system, it's going to make them look anemic again. They're not necessarily anemic, but it's just that excess volume of fluid. So we're going to focus on treatment, management. So these kids are probably going to be put on bed rest. They may be hospitalized if hypertension and gross hematuria or oliguria occurs. You're going to monitor their vital signs. Again, that blood pressure can get as high as 200/120. And we talked about what those symptoms could be. You want to feel the pulse. What does it feel like? Not just the beats per minute. You want to feel those pulses on those extremities. Because if they're swelling, how's that pulse going to feel? Diminished. It's not going to be as bounding, right? A thready feeling, because it's going to be more tissue and pressure put on them. You're going to monitor their weight. Monitor their intake and output. If they have fluid volume excess, what is another assessment we should consider? So if they have edema, what's another important? Huh?
Pressure.
Okay, sodium, but
Pressure.
cardiac, but another kind of close to the cardiac issue.
Compression socks.
Possibly.
Monitoring the kidney function.
Possibly. What else is close to the heart? The lungs. Good job.
We got their attention.
And work it out of you, but we got it. So, again, if they have fluid volume excess, like I said before, we're looking at our ABCs. So what assessment are we going to do? We're going to listen. We're going to auscultate. Because if they have fluid, what are we going to hear? Crackles, rails. Okay? We're going to hear that fluid in there. Okay? So they can have edema all over. It can be in the extremities, eyes. It can also be in the genitalia. Okay? That fluid's got to go somewhere. So how do we improve edema? Lasix, right. So these kiddos are probably going to be on a diuretic. Lasix is our most common one we use. So these kids are going to be on furosemide. We're going to use furosemide for mild to moderate hypertension and edema as long as the kidneys are functioning properly. Okay? We're going to limit our salt intake and fluids. Of course, we need to make sure they're getting enough fluids, but we also need to make sure we're not overhydrating them. We're going to also increase the protein in the diet. Why would we do that? Okay, promote healing. But protein also pulls fluid into the interstitial space, and losing protein in urine, so it needs to be replaced. Okay, so that protein is being pulled into that fluid. The body needs protein for the muscles to function, correct? So we need excess protein because all that, what the protein they're normally taking is being pulled into that fluid. Okay. Antibiotics may also be administered to ensure that the original infection that caused this is gone. Okay. So that might use, that's Lasix if kidneys are functioning. Okay, that's Lasix. We're going to use Lasix. Quiz. Which is the signs and symptoms of glomerulonephritis? Correct. Hypertension. Okay. That is your most common sign and symptom that you potentially could see. Good job. So nephrotic syndrome or nephrosis. So it's alteration in kidney function due to damage to the basement membrane of the glomeruli. Okay. So that basement membrane around it is what's damaged. Most common presentation of the glomerular injury in children, this is the one you're going to see the most, okay? Can be primary or secondary. Primary, we really don't have a cause. We don't know what has caused it. Secondary causes due to systemic disease, drugs, or toxins. So things that you're going to see is massive proteinuria, okay? Hypoalbuminemia, okay? So hypo means low, so the albumin is going to be low. And it's hyperlipidemia, so what's hyperlipidemia? High cholesterol, basically, okay? And edema. So edema and ascites, it develops gradually over several weeks. And this is going to be your most common symptom you're going to see. It starts on waking with the periorbital edema and then shifts throughout the day to the abdominal and lower extremities. So snug fitting clothes or shoes, you know, that can sometimes, what do we think when a kid, we put a new outfit on and it doesn't fit right, or they've worn it a couple times and now it's snug. They grew, right? We're not so worried about anything else, they just grew a little, okay? Right, they gained weight over the spring break, or like my daughter said, she gained weight over COVID, you know. So you think, oh, they grew some, okay? Because we're thinking several weeks, because kids kind of have those growth spurts. If you are away from them for a week, you see them again, you're like, oh my gosh, did you grow 2 feet? You know, so they do grow quickly. So we might associate that with growth. Pallor, hypertension, irritability, anorexia, fatigue, hematuria, decreased urine output, non-specific malaise, like there's no reason we can pinpoint, they're just being, like, don't feel good. Frothy or foamy urine. The child eventually becomes malnourished due to the loss of protein in the urine. So the skin becomes shiny and pale with prominent veins, and hair and nails can become brittle. So how are we going to manage and treat these kids? So we're going to monitor labs again: UA, albumin, sodium, BUN, cholesterol, electrolyte levels. Primary objective for treatment is to decrease excretion of the urinary protein and maintain protein-free urine. So we're going to place them on bed rest and hospitalized during that acute phase, especially if they have severe edema or there's major infection and remission. So we're going to give antibiotics. We're going to give steroids like prednisone, immunosuppressants. We're going to control the edema, so we're going to do a salt-restricted diet. Establish good nutrition, okay? So there's no reason to increase to a high-protein diet as it has not proved to change the disease outcome. So in this disease, even on the other one, we can increase the diet with protein. In this one, in the nephrotic syndrome, it has not shown to help increase the protein in the kiddo, okay? So prognosis in this disease is usually good, and they potentially can have relapses, okay? So with your other one, your acute glomerulonephritis or AGN, they're going to increase the protein. You may not, and they're most likely not going to relapse. They're not going to have another occurrence. But with nephrosis and nephrotic syndrome, we don't increase protein, and this is something that can relapse, okay? So renal failure. Renal failure can be acute or chronic. So acute occurs suddenly over days or weeks. It may be reversible. Chronic is kidney function has diminished gradually over months or years. It's characterized by azotemia and oliguria, and eventually anuria. So that means like they're not pee. Okay, A means none. So azotemia is an accumulation of nitrogen waste in the blood. That's what azotemia is. An accumulation of nitrogen waste in the blood. For ARF, so acute renal failure, we're going to treat the underlying cause. For chronic renal failure, or CRF, we're going to make adjustments to treatment that may be needed due to the child's changing status, because they're going to be constantly up and down with their lab work. We're going to monitor the BUN and creatinine and electrolyte levels, and they may need dialysis to help clear out all of those excess toxins in the blood. Hemolytic uremic syndrome, or HUS or HUS, it's the most common cause of acute renal failure in children. Polycystic kidney disease, this is a genetic disorder. This is usually caught on ultrasound in utero, okay? Something that they'll catch, because when they're looking at doing that growth scan, they look at the brain, the heart, the lungs, the kidneys, the stomach, they look at everything, the bladder, that they can see. And so that's when they're going to see polycystic. So they're going to see multiple cysts inside that kidney. Oh, quiz. Nursing management of nephrotic syndrome includes, and that's that periorbital swim. Okay, so this one is a harder question. Okay, so let's break it down. So with nephrotic syndrome, we need to promote diuresis, prevent infection, and provide emotional support. So, yes, we're going to monitor albumin levels, but are we going to weigh weekly? How often are we going to weigh? Daily. Okay? Avoiding diuretics and encouraging steady fluid intake. What is wrong with that one? Avoiding diuretics because we need to pull some fluid. Increasing sodium intake and limiting intake. Okay, so increasing sodium, what's that going to do? They're going to have more edema. And limiting sodium or limiting protein intake, remember with it, we haven't seen a difference even if we increase, but we don't want to limit because we still need protein for their body, right? Okay. Okay. So hemolytic uremic syndrome. This is children less than 4 years old that are most affected with this medical diagnosis. So you're going to have 3 symptoms, a triad of signs. Okay? You're going to have hemolytic anemia, thrombocytopenia, and acute renal failure. So a child from the age of 2 to 12, their normal hemoglobin is 10.2 to 13.4. It might be important to know that range.
What was it again?
10.2 to 13.4, and that's from your book.
What were the ages you said?
2 to 12. Two years old to 12-year-old. So hemolytic uremic syndrome is caused by E. coli found in like unpasteurized milk and juices and undercooked meats. Can be found in like petting zoos or animals from the house. Okay, so like we have chickens. We used to also have a red slider turtle, okay? Those carry bacteria like E. coli and salmonella naturally on their exterior. And so, you know, I always have told my kids anytime, play with the animals, even dogs, cats, whatever, wash your hands before you do anything else, okay? And so that's because they can then infect themselves with that E. coli, okay? Especially dogs. That's why you do not let dogs lick you in the mouth. What do dogs do? They eat poop. And they lick their rear ends, okay? Just grosses me out. Their mouth is a bed of bacteria, okay? That's why dog bites are the worst. They can get infected so easily, okay? So don't, like those Funny Home videos and they got the little baby and the dog just licking them in the mouth and I'm like, don't. Disgusting. Okay. So, E. coli produces a toxin that attaches to the glomeruli, collecting ducts and the distal tubules of the kidney. So that E. coli just attacks and sits in that kidney. Toxins damage the lining of the glomerular arterioles, leading to swelling of the cells of the endothelium, leading to occlusion of the cells with platelets and fibrin clots. This leads to damaging of the red blood cells, and then you have hemolytic anemia, okay? Because if those red blood cells are damaged, can they carry oxygen the way they're supposed to? No. So they're going to be, their anemia is going to be present. So you have clustering of platelets of the damaged endothelium, which leads to thrombocytopenia. So the platelets and fibrin occlude at the cells. Then you have clustering of the platelets of the endothelium, decreased platelet count, which causes thrombocytopenia. And I will upload this with my notes and it will kind of have that pathology. Yes.
Time where they won't have like the triangle signs, like will they have two of them?
Possibly. You may not always see all three, but more times than not, you'll see all three. Okay. If you catch it early, they may not have all three. Okay. But anytime you have those three together, you're automatically going to think of hemolytic uremic syndrome. Okay. Which is caused by what? E. coli. So some signs and symptoms we're going to see. So they're going to have severe gastroenteritis with diarrhea. Okay. And it precedes the development by 1 to 2 weeks. And then the child is 1 to 5 days without symptoms. So first they're going to have this gastroenteritis with diarrhea. Then they're going to go a short time without symptoms. And then it's going to develop. Then you're going to have symptoms onset of the HUS, which is purpura, pallor, bruising, oliguria, irritability. And it may become more severe, so you might see fever, abdominal pain, vomiting, blood-stained diarrhea, jaundice, circulatory overload, or have CNS involvement such as seizures or lethargy. Treatment of HUS, we're going to focus on the complications associated with this acute renal failure. So fluid restriction. We're going to promote high calorie, high carb diet for healing. Low protein, sodium, potassium, and phosphorus diet, because again, that kidney's not able to function properly. Medications. So we're going to have calcium gluconate or calcium chloride. This helps lower the potassium because again, that kidney cannot process that potassium. Aluminum hydroxide to bind to phosphorus. K-exolate to remove excess potassium. And antihypertensives. So what are some other management responsibilities we are going to have as a nurse? What are we going to monitor for? Intake and output. Vital signs. Labs. We're going to monitor those electrolytes. Any pain. Okay, skin integrity. Airway, of course, always. Level of consciousness, okay, because these kiddos can become toxic because they have all this excess in their body. And of course, medication administration, okay, that's our role. So now we're going to talk about polycystic kidney disease. Again, this is one that is genetic, okay. It can be recessive or dominant. These are also associated with some liver abnormalities along with the polycystic kidney disease. So if you see polycystic kidney disease, they may have some other liver abnormalities. So newborns who have the recessive form of the polycystic kidney disease are born with enlarged kidneys. These kids typically die within the first month of life from pulmonary hypoplasia due to oligohydramnios in utero, which is due to severe intrauterine kidney disease. So remember how the amniotic fluid is made, okay? Baby swallows, pees it out. Baby swallows, pees it out. Your body naturally rebuilds it a little bit, but the most common way it's replenished is baby swallows, pees it out. So if you don't have much fluid around baby, okay, they can't swallow and pee it out because, or if they do swallow, they can't pee it out properly because their kidneys aren't functioning properly because of the polycystic kidneys, because it just has all those cysts in there. Their anatomy is not normal in that kidney to properly process that amniotic fluid. So then if they don't have fluid to be able to lubricate those lungs become hardened, okay? And that's that pulmonary hypoplasia. So this is very common in women whose water breaks early and they are able to carry to viability and then the baby delivers. They basically have very hardened lungs, tight lungs, okay? You're also going to have other signs. You'll see low set ears. They're going to have a small jaw or flat nose. And they're also going to be small. They're going to have that interuterine growth restriction. Hypertension develops as an infant. RDS and feeding intolerance develops from those enlarged kidneys because they're not able to process again. So supportive treatments are provided. So you're going to give medications like diuretics for hypertension, antibiotics for UTIs. You're going to manage the fluid and electrolyte abnormalities. In children, growth hormones may be needed because growth failure occurs. So remember, the ones that usually don't make it are the recessive form, okay? Your dominant form, those kiddos can continue past that young age. Many children develop end-stage renal disease by age 12, but survival rate is only about average of age 15, okay? So some may pass at a young age with recessive, and then with dominant, they can continue to live on with assistance with medication, but they're still not going to live out a full life. Quiz. Multi-select, so more than one. What are the triad of symptoms with hemolytic uremic syndrome? Correct. So, acute kidney injury or renal failure, okay? Same difference. Thrombocytopenia and hemolytic anemia, your triad of symptoms. So, structural defects of the reproductive system. So, we talked about the urinary, so now we're going to talk about the genito. So, we have phimosis. This is unable to retract the foreskin due to natural adhesion. So treatment for this is circumcision or topical steroid cream. Some newborn boys, you'll even see they'll have a really tight band at the tip of the penis of that foreskin and you can't pull it back. And it's not so much adhesion, it's just that skin is tight. But if mom, as that baby goes home, doesn't continually pull back that foreskin, what happens is it slowly adheres to the tip of the penis, okay? So you can then do a circumcision to remove that excess skin or use steroids to help kind of break down that adhesion that's formed and have them pull that foreskin back. Cryptorchidism, it's undistended testes, inguinal hernias, hydrocele, those are fluid-filled masses in the scrotum, or testicular torsion. So cryptorchidism is the failure of one or both testes to descend normally into the inguinal canal, into the scrotum. Absence of the testes within the scrotum can be due to 3 different reasons. So undescended or cryptorchide testes, which can be characterized according to the location. So they could be in the abdomen, proximal to the internal inguinal ring. Canalicular, which is between the internal and external inguinal ring, or ectopic, which is outside the normal pathway of descent. So they are not up in the abdomen, they're in some odd spot, okay? Retractile testes can be identified anywhere within the path of descent. So they're moving down, but may not be all the way down. Most commonly found in the groin. They're more introverted to an inguinal or abdominal position and not truly that cryptococcus. Can be gently moved into the scrotum without residual tension and doesn't require treatment. Okay, so basically these are testes that are on their way down, and you can physically, the doctor can physically move them into place. Okay, because there's nothing adhering them to where they are. Anorchiasm is a complete absence of testes. Okay, so that's why it's always important to assess a newborn. You're going to feel the scrotum for one, hydrocele, which is those fluid-filled sacs, and testicles. If you don't feel one or the other or both, you need to let the pediatrician know, because then they may need to do an ultrasound to find where they are. Okay, because it is important to know if they only have one or they don't have any at all, because that's going to affect their hormones, right? Their reproduction and their growth. Okay. So diagnosis is usually detected during a newborn exam. You're going to prevent cremasteric reflex. Okay. So what happens, that cremasteric reflex is where you actually, we're going to talk about it in a second, but you actually kind of rub the inside of their thigh real lightly, and those testicles will kind of pull up. So you don't want that. You don't want them pulling back up, because you need to feel them. Okay. So ultrasound or CT or an MRI. So during the exam, the nurse can place the child in the squatting position and apply a firm finger pressure on the external ring before palpating the abdomen or genitalia in order to prevent the cremasteric reflex, which is a natural reflex of the scrotum and testes to raise or retract towards the body when the thigh is stroked. Okay, so you're going to put them kind of like in a squatting position. So you're not, you can feel and you're not rubbing against the thigh. So treatment for this, if retracted, they usually can be manually manipulated back into place. They usually descend spontaneously by 1 year old. So they may have HCG or luteinizing hormone in their system, okay? Or there could be orchiopexy. We're going to talk about that next. So this, yes.
So could this cryptochytism, like make you sterile, lead to sterile?
Possibly, because remember, heat reduces the amount of sperm that is produced. So if you don't get them back in the testes, yes. That's why if a husband and wife or a man and woman or whoever trying to get pregnant, they'll, a lot of times, if men wear like tight briefs, they'll have them wear boxer briefs or boxers for a while, because the closer the testicles are to the body, the more heat is produced and less sperm they'll produce. So yes, they could, if you don't move them down. Yes. Okay. Okay. So testes are brought down into the scrotum and secured. This is a procedure, this orchiopexy. This is the procedure they're going to do to help bring those testicles down. So they're brought down and secured. An incision is made in the location of the testes, either in the abdomen or the inguinal area, wherever they are. The blood vessels are disentangled to allow the testes to reach lower into the scrotum. A second incision is made in the scrotum at the point where the testes is stitched to the inside wall to keep them in place. So they actually bring them down and then stitch them in place so they can't go back up. And they're going to use a dissolving stitch, okay? We just need it to stay in place until the body kind of adheres them there, and then that stitch will dissolve. This is usually done between 6 to 12 months of age, okay? You're going to have less physiological problems and increased chance of fertility if it's performed at an early age. course, you don't want to do it on school-age children because you've got that body image issue or peer embarrassment, you know, because they're going to go to the bathroom and, of course, they're going to have bruising and sutures, you know. They don't want to have their friends know. Orchiopexy prevents damage to the testes by increased body heat. And this is going to help reduce, we want to try to avoid trauma to that testes or a torsion. So increased incident of tumors does occur with these. So risk of testicular cancer is about 35 to 50 times greater in men who have had the history of the cryptorchidism. So they have a higher risk of testicular cancer. Okay, so inguinal hernia or a hydrocele. We have two different, they're both different, okay, they're not one and the same. So an inguinal hernia is a painless inguinal or scrotal swelling of abdominal tissue extending into the inguinal canal. So think about a hernia. So what it is that muscle or tissue, there's a separation. And that abdominal intestine or whatever else, fat can get through there. And you're going to see a bulging. Okay, so these baby boys, a lot of times, or girls, you're going to see like when they cry and get mad and they straighten their abdominal muscles, what pushes that out more, and you're really going to see them more pronounced. Okay, so mom and dad may not see it initially because they're relaxed, but with crying or tightening of those abdominal muscles, you're going to see that bulging in that bend of the leg. It's right at the bottom of your pelvis, kind of in the bend. Okay. Again, may become more apparent during straining. So they may not see it until they see that baby mad, like while they're changing their diaper. You're usually going to do this surgery by 3 months old, okay? Because with hernias, we know if that bowel gets entrapped in there, it's going to be bad. So we need to fix it quickly. So a hydrocele is a fluid-filled mass in the scrotum, and these usually resolve spontaneously, okay? And what you'll feel, it feels different. A testicle is firm, okay? When you palpate it, a hydrocele, you can feel the fluid move, okay? So there's a difference. You can feel the difference between the two. So testicular torsion, this is emergent, okay? This is when the testes rotates on that spermatic cord, heading off blood supply. It actually twists around inside that testicle, causing ischemia. So it's not going to get blood supply. Symptoms, they're going to have severe pain and redness in the scrotum, nausea, vomiting, abdominal pain, swelling at the site, and absent cremasteric reflex. So again, if you go in and rub that inner thigh, that testicle is not going to automatically pull up because it's going to be swollen, torsions happening, you've got edema, so it's not going to lift, okay? Surgical treatment is important to save the testicle. So they could do what's called an orchiectomy if it's necrotic. So they would have to remove that testicle if it's already showing signs of necrosis, okay? Because it's not going to be viable.
What causes it?
It's random. We really don't know. It just happens, just like with an ovarian torsion, because your ovary can do the same thing.
So is it like seen at birth, or can it develop like?
Anytime. You are going to see it more often in younger males than you do older males, kind of in that puberty, post-puberty time, but it's random. We really don't know what really causes them. It just happens.
So nothing really adheres, it just randomly turns?
Yeah, just randomly twists around itself. With ovarian torsion, sometimes you can have like PID, pelvic inflammatory disease can kind of be a precursor to it. But with testicular torsion, you know, sometimes trauma possibly, but a lot of times it's just random. It just happens. So what is our nursing management? What are we going to do? So psychological support. These poor guys are going to be scared to death. Okay? They're going to have questions about their fertility. We're going to have to educate them about the care of that incision and pain medication. They're going to have an order for no lifting of heavy objects for 4 weeks and should not participate in any kind of strenuous activity for 2 weeks. Okay? Including sexual intercourse, because that's going to be one of the questions. Okay? I've taken care of a few. It's in OB, it's funny. Sometimes if the surgical floor is full, but they need a patient to come down just for a few hours before their discharge to make sure they recover. If we're not busy on OB, we'll get these patients. So I've actually cared for a couple young guys that had this happen, you know. And so, that's, you know, they're going to have questions. Can I have babies? When can I resume sexual activity? You know, so you have to educate because you don't want any strenuous activity, especially if they were able to save the testicle, because you don't want it to torsion again. Okay. Not necessarily. No, it's just like I said, random. It just can happen. Okay. If you can save the testicle, yes, and you remember you have 2, so yes, you can. But of course, if it's necrotic and you have to remove it, then it kind of reduces the amount of sperm they'll produce. So, but most of the time, you have to think about the millions and billions of sperm that's released. So it usually doesn't cause an issue with it. So, okay. So now we're going to do some NCLEX style questions related to what we learned in class today. Okay. We're going to break them down. So I want everybody to kind of look at the question. So assessment of a 2-year-old by a nurse in the emergency department reveals the following: edema, hematuria, hypertension, and oliguria. Which of the following would the nurse assess as a most likely cause of these symptoms? Okay. So think about what we, and then you can look back in your notes if you want. Okay. Can someone immediately take one off?
2.
Okay. 2. So why? Tell me why. You're correct, but tell me why.
UTI doesn't cause edema, hematuria.
Okay, right. We know UTI doesn't cause edema. It might cause hematuria. That is a symptom. Hypertension, no. And it possibly could cause a little bit of oliguria, but not so much. There's urine there that maybe they can't completely avoid. Okay? So is there another one? 4. Okay, 4. Because what is that? Tell me what that is.
Plastic bag.
Right, we're going to put the plastic bag. The bladder's on the outside of the body. Basically, there's an opening through the abdominal wall. Okay. So what about the vesicorect? The V-R, V-U-R. Because I can never say them. Okay, so the urine refluxes. So what are our symptoms? We look back up there at VUR, see what our symptoms are. Okay, so we've got backward flowing. Do we have hypertension? Okay. Do we have Algeria? Not necessarily, right? Okay. So, which one is it? Acute renal failure. Now this one's a little harder because we just learned our symptoms today, okay? But you've got to break it down. You've got to look and see what is each one, what are their symptoms that you know. Learn those symptoms for each one. So that way you were able to immediately take 2 off, right? So you had 2 left. So then you have to look back at your symptoms, which are edema, hematuria, hypertension, and oliguria. So then you have to decide out of those 2, which have those 4, okay? So again, acute renal failure, there are several things that can cause acute renal failure, including hemolytic uremic syndrome, nephrotic syndrome, and severe dehydration. Most children with acute renal failure are admitted to pediatric intensive care. An upper respiratory infection would not cause any of these listed. Bladder extrophy is a congenital defect, and the VUR is a backflow of urine from the bladder to the kidneys. Question 2. The student nurse is working with the nurse caring for the school-age child diagnosed with acute post-infectious glomerulonephritis. The nurse would be concerned about the student nurse's knowledge for caring for this child if the student nurse said which of the following. Okay. So we have glomerulonephritis. So I need to monitor the child's blood pressure closely since hypertension is common with this condition. It is important that the family understands the child is on a no added salt, low protein diet. It is important that the child receive antibiotics to treat the acute post-infectious glomerulonephritis. Or I must monitor the child's lung to assess for pulmonary effusion. So we've got student nurse, okay, and we've got to see her knowledge, okay, so the nurse would be concerned. So we're looking for something that's wrong, right? Because we're concerned. So we need to look back at our glomerulonephritis to see what are our symptoms, because that's kind of what we're looking at, right? So somebody tell me some symptoms of glomerulonephritis. Okay, so hypertension. Okay, so knowing one's hypertension, I need to monitor the child's blood pressure closely since hypertension is common with this condition. Is that wrong? No. Okay, that's true. Okay, we know that's correct. So what else are some symptoms?
It's caused by a bacterial infection, so you'll give them antibiotics.
So we're post-infectious glomerulonephritis. Okay, so 2, why are we getting rid of 2?
Alpha, so maybe there were.
Okay. Okay, so no added salt, low protein diet, so that's correct. We don't want to increase our salt. Okay, so now we're down to 3 and 4. So someone said 3 we could take off. Okay, so we only learned about glomerulonephritis today, right? But what's our key word before this? Post-infectious. What does that mean? After. Okay. So, are we going to treat a child that doesn't have an infection with antibiotics? No. Okay. So, I must monitor the client's lungs to assess for pulmonary effusion. Is that true? Because they have edema, right? We know edema can cause fluid in the lungs. So, this one, you know, we had to break down, we had to look at those signs or those symptoms that they're going to have. But we also, again, when you go in for your NCLEX, you may know part of the diagnosis. You know what glomerulonephritis is. But you're like, I haven't ever heard of post-infectious. But think, use your brain, okay? Yes?
Like, so to eat a high protein diet to pull that sugar.
Well, let's look. Yeah, high protein. So, but we also know that they are on a no salt added. Now, I will tell you some of these questions that are on here. Sometimes we do have to email in about. I'm going to make a note. Level 2 sometimes catches them. Because these are pulled from your book, exactly.
Is correct as well, right?
Answer 2?
Answer 2, yeah.
Possibly, yes. If it was a select all that apply. Okay. But the one that we were looking at would be 3. Yeah, it was supposed to be high protein on that one, I think. So we do know, let's see what they say on there. Let's see anything. This child would be on a no salt added low protein diet. Well, that's not what the book says, so we will email them about that. Good catch. Okay, so question 3. Which issue is important to discuss when educating a family about nocturnal enuresis? So let's look at them. 1, limit daytime fluid. When are we going to limit fluid? So that's not correct, right? Okay. Have the child double void before going to bed. Maybe. Okay, we're going to go on down. Administer laxative daily. Lord, no. Nobody wants to do that. I don't want to clean that much up. So refer the child to counseling immediately. Maybe. But we don't know, this doesn't tell us if it's primary or secondary, right?
That's extreme.
That's extreme. Right. Immediately. That's the term we're looking at. So this is extreme. Okay? So having the child double void before going to bed is the correct answer. Okay? They may eventually need to be referred to counseling if all of our other interventions are not working. We're going to try some other interventions primary to then immediately sending them to a therapist or counselor.
What does it mean by double voiding?
So basically have them pee twice. Make them pee, wait a few minutes, make them pee again to make sure they've completely emptied that bladder. Okay, because if they have a small bladder due to whatever reason, because that can be one reason for primary, they have a reduced bladder capacity, you're going to reduce their intake after 6 p.m. and then you're going to have a void twice prior to bed, so that way we can hopefully empty that bladder completely. Okay. Okay. Let's rationale. So counseling is not always indicated. Immediately is extreme. Promoting regular stools and having a child double void before bed are appropriate interventions. Limiting daytime fluid has not been shown to be effective. And we don't want to make them poop, poop, poop. Okay. Question 4. A child with nephrotic syndrome is placed on corticosteroids. The nurse should educate the family about which effects of corticosteroids. Okay? So we know what corticosteroids are, right? We have an idea. It's a steroid, prednisone, all those other ones. Okay. Okay. So someone said gain weight. It's going to cause them to have a little bit more edema. And there is one characteristic of steroids. Mood phase. Okay. So if you know that, then you're going to know it's mood phase. But say you're not sure. Okay. You know edema is going to occur with steroids, correct? Okay. Impaired balance, is that really going to be caused by a steroid? No. Okay. Decreased appetite increases their appetite. These kids eat you out of house and home. Hair loss No, that's not a common side effect of steroids. So by deduction, if you don't know that moon face is a common side effect of steroids, you know steroids is going to cause edema. So you could say, okay, this is more idea. So if you saw moon face and didn't know what it means, what would you say? Swelling, right? Swelling in the face. No. Full moon. Full moon, not crescent. Okay, so again, side effects of corticosteroids include moon face, increased hair growth, increased appetite, and mood swings. Impaired balance is not associated with corticosteroids. Question 5. The nurse is meeting with the mother of the school-aged child. The mother is concerned that the child still wets the bed at night. The nurse would include which of the following facts in a teaching session with the mother and child. Select all that apply. Okay, he's still wetting the bed, so he has nocturnal enuresis. Okay, so we've got more than one answer. So let's play true or false. Okay, so limit excessive fluids in the evening. Okay, develop a punishment plan for the bedwetting episodes. False. Okay, consider the use of enuresis alarm. Okay. Develop a positive reinforcement reward system. Okay. Avoid caffeine. Did we say anything about caffeine?
Caffeine is a diuresis.
It is. Good job.
You shouldn't have caffeine.
Right. Well, my kids love coffee, so. True. Right. So we didn't even talk about caffeine being a problem, but because you guys knew caffeine is a diuretic, right? So there. So you were correct. So this is where people get scared. Oh my gosh, I picked too many. Surely there's not 4 correct ones, right?
Yeah.
You do it all the time, right? Oh my gosh, I think I picked too many. If you can say true to 4 of them, 4 of them are true. Don't change it. Okay? That's where you get yourself psyched out. Like, oh my gosh, I picked too many. Or I didn't pick enough.
I guess like that one, there's like only one.
Right. Yeah.
Like out of 6 options, only one.
Right. Well, I will say on the NCLEX, there's going to be more than 1. You're at least going to have 2 correct if it's a select all that applies. Okay? Okay, let's see who won. Oh, good job, 3rd place. Good job, 2nd place. Yay! Okay, so we will take a 7-minute break. I have uploaded, I've got to open it, on Canvas. There's a short case study you guys can do. You can use the internet since most of y'all don't have your books, but there are some maternal child books in the back if you want to use them. Just a second. So y'all can have a 7-minute break. When you get in, I will have the assignment under unit E2 for y'all to complete in the last 30